Welcome to Integrating Oral Health into Oregon's Coordinated Care Model. During today's webinar, we'll hear state and local perspectives on Oregon's experience to date integrating oral health into overall Medicaid system transformation. This is Carrie Hanlon, Project Director at the National Academy for State Health Policy, or NASHP, and I will moderate today's webinar, which is supported by the DentaQuest Foundation. Connecting oral health and overall health is a critical topic since we face rising health costs, tight state budgets, and opportunities for improved physical, behavioral, and oral health outcomes. Today's webinar is a result of a case study about Oregon that NASHP has conducted over the past year with DentaQuest Foundation support to learn about Oregon's experience. We have over 300 registrants today, and those interested in whole person care, exploring global budgeting and value-based payment or quality measurement can all learn from Oregon's ongoing integration efforts. NASHP will be releasing a companion report about Oregon on August 15th. Before reviewing today's agenda, I wanted to go over a few housekeeping items. You should be able to hear the webinar through your computer speakers, but if you experience audio issues, you can call the number you see on your screen. Participant lines are muted if you have called in, so please submit questions or comments in the chat box, which is on the bottom left-hand side of your screen, and you can chat in questions at any time. Today's materials will be available on NASHP's website next week, nashp.org. And finally, you'll be directed to a short survey at the end of the webinar, and NASHP really values your feedback. Today, Chris DeMars and Bruce Austin of the Oregon Health Authority will provide an overview of Oregon's coordinated care model and describe how oral health fits in, including incentives, measures, next steps, and lessons learned. We then will hear two brief local spotlights from Laura McKean of All Care CCO and Linda Mann of Capital Dental Care, who will share insights from their organization's efforts to improve oral health in Oregon. After each presentation, we'll pause for a couple of clarifying questions. And once we hear from all presenters, we'll move into a short facilitated Q&A based on the questions and comments you submit. Speaker bios were posted at the registration link, and as I'm sure you noticed, we have an experienced panel today, so let's get to it. We begin with an overview of Oregon's Medicaid system transformation, including oral health, from Ms. Chris DeMars and Dr. Bruce Austin with the Oregon Health Authority. Chris is administrator of the Transformation Center, and Bruce is Oregon's statewide dental director. Welcome, Chris and Bruce. I'll turn it over to you.
Thanks, Carrie. So once again, this is Chris DeMars, and I'm going to be going over Oregon's health system transformation on kind of a broader level, and then I'll pass it along to Bruce, who will talk about our oral health integration. So next slide. Oregon's been working toward reforming its healthcare delivery system for well over 5 years, so though the official reform occurred in 2011, when there was strong bipartisan legislation led by the previous Oregon governor, who was also a doctor and had spent years advocating for delivery system reform. This legislation in 2011 proposed a statewide system of coordinated care organizations, which are essentially Medicaid ACOs. They're networks of all types of physical health, addictions and mental health, and oral health care providers who work together to serve Oregon Health Plan or Medicaid members through implementing what we call the coordinated care model. After the 2011 legislation passed, there was a whirlwind of activity in 2012. The Oregon legislature passed additional legislation that actually created the CCOs. Most of our 16 CCOs launched a few months later in August of 2012. And Oregon Health Authority leadership worked with the Federal Center for Medicare and Medicaid Services to update our 1115 Medicaid waiver, allowing us the authority to implement CCOs. While behavioral health was folded into CCOs' budgets when they were created, oral health was included into their budgets later, in July of 2014, because it took a little more time to work out the details with regard to folding oral health into the CCOs' budgets. And then earlier this year, Oregon received approval from CMS to renew our 1115 waiver for another 5 years. I'll be providing more detail on this later in the presentation. Next slide, please. So in Oregon, we call the model that CCOs are implementing the coordinated care model. When we started implementing the coordinated care model while we started implementing it with our Medicaid population, it's a model that can be and is being adapted for other payers, such as Oregon's government employees and teachers. You see the 6 components of the model here. Separately, these elements all help produce the triple aim, or better health outcomes at lower prices. When they're used together, their effectiveness in achieving the triple aim increases. Later in the presentation, we'll be discussing paying for outcomes, sustainable rate of growth, and measuring performance, the right-hand side. The model also focuses on engaging the patient to support shared responsibility for health and providing incentives for preventive care, such as low or no-cost screenings or well-child visits. It also focuses on transparency and price and quality, which includes transparency in provider performance and CCO performance, which we'll be talking about, and then evidence-based best practices to manage and coordinate care. And one example of this is our patient-centered primary care home model, which is Oregon's version of the primary care medical home model. Next slide, please. So this slide shows how care for Medicaid members has changed with CCOs, basically how CCOs are implementing the coordinated care model. For example, the delivery of care used to be fragmented and siloed, and so did the funding streams. Now CCOs receive a global budget for physical, behavioral, and oral health care, which grows at a 3.4% rate annually per our agreement with CMS. And this is 2 percentage points lower than it was when the CCOs started. Because of our success in holding down costs, we've avoided expenditures of over $1.4 billion since 2012. Before CCOs, payment happened on a volume or fee-for-service basis. Now, part of CCO's payment is based on their performance on certain metrics. And you'll hear a little more about the oral health metrics from Dr. Bruce Austin later. The CCOs have been pretty successful in this area as well. For example, we've seen decreased emergency department visits of 23%, increased developmental screenings of 70%, and increased primary care, which has tripled since the baseline year since CCOs were created. CCOs also have the ability to pay for services outside of traditional healthcare services, and we call them health-related services. The primary example that was used when CCOs were created was the ability to pay for an air conditioner to keep an elderly woman with heart disease out of the emergency room. We've found that CCOs are using health-related services for a wide variety of services, such as gym shoes, cooking classes, and short-term rental assistance. And then finally, CCOs are expected to focus beyond individual patients to their communities. They're each required to have what's called a Community Advisory Council, which is comprised of Medicaid members and representatives from local government and community-based organizations. And they're responsible for developing a community health improvement plan that identifies strategies to improve health of their entire community, not just their Medicaid members. Next slide. So this map shows the distribution of Oregon's 16 CCOs. As you can see, their geographic areas vary widely. Most areas have just one CCO, whereas 2 parts of the state, the Portland metropolitan area and Southern Oregon, have overlapping CCOs. The CCOs cover approximately 95% of Oregon's Medicaid population, and the Medicaid population in total is about 1 million people, or a quarter of all Oregonians. There are also 7 dental care organizations, or DCOs, and they're not shown on this map. But I want to point out that contracting between the CCOs and the DCOs can be complicated because their regions don't overlap. They're not the same. CCOs used to be required to contract with all the DCOs that were located in their area. But based on recent legislation, CCOs are no longer required to contract with all the DCOs in their area. They are still required to offer oral health services, and Dr. Austin will be providing a little more detail about this as well. Next slide. So as I mentioned earlier, Oregon's 1115 waiver that provided us with the authority to create CCOs, it was renewed in January after an expedited process through June of 2022. The goals of our renewed waiver are basically to continue along the path of health system transformation that we've been traveling with some additional enhancements. So we plan to continue to focus on integration of physical, behavioral, and oral health care through a performance or metrics-driven system. We are going to be focusing more intently on addressing the social determinants of health and health equity. We've continued to commit to an ongoing sustainable rate of growth through advancing the use of value-based payments and promoting increased investments in the health-related services that I just described. And we plan to continue to expand the coordinated care model. Next slide. So as I mentioned earlier, behavioral health was integrated with physical health in CCOs almost 2 years before oral health was added. we thought it would be useful to share some of the lessons learned from our behavioral health, physical health integration efforts that could be applied to oral health integration as well. So in instances where there's co-location, where there's a behavioral health and physical health providers that are located on the same site, we've found that it's not as simple as putting a behavioral health providers and physical health or primary care providers together, just co-locating them. It's really important to be clear on the roles that each provider is going to play and clearly identify the workflow changes for both the primary care and behavioral health providers. And then in addition, in terms of the culture change that needs to happen, we've found that the behavioral health providers and primary care providers, they will learn best from their peers and other clinics who have experienced success in these efforts. And so we've tried to kind of do some sharing and partnering to help spread the success and knowledge. And then in situations where integration consists of a primary care provider coordinating connections with behavioral health care, so not co-location, but more coordinating across sites, we found it's important for the primary care providers to close the loop on the referrals they make to ensure that the follow-up with the oral health provider occurred. So next I'm going to pass along to Dr. Bruce Austin, who will be providing specific information about dental integration in Oregon. So next slide.
Thanks, Chris, and hi everyone. Thanks for joining us. I'm Bruce, and I've been the State Dental Director for Oregon for about 2.5 years, so a lot of this good work has happened before I arrived. And early on, we were fortunate to have a history of leaders who recognized the value of the integration of oral, behavioral, and physical health care as central to our goal of providing whole-person coordinated care and also promoting health equity. And when I spoke with some of the early leaders that were part of the creation of this system, I learned that from the outset it was understood that oral health was inseparable from overall health, and the prioritized list was created with that in mind. And our prioritized list is a ranking of healthcare condition and treatment pairs in order of clinical effectiveness and cost effectiveness. Treatments that help prevent illness are ranked higher than those services that treat illness after it occurs. And in Oregon, we're fortunate to be one of the 15 states that's considered to have fairly extensive adult dental benefits, even though it's not required. We realize how fortunate we are, and this goes back to our history of the creation of the integrated prioritized list and health plan. And we're also ready if the conversation or question ever arises about can we still afford to offer adult dental care, we'll be ready to show why we can't afford not to cover it. So next slide now. So what is oral health integration? It's not one standard easy answer, we found out. The definition can vary depending on the viewpoint of the individual or the entity, and it can be co-location, such as placing a dental hygienist and or a dentist in a medical facility. We've done that. I'll tell you a little bit more about that later. It could be creating or encouraging relationships between medical and dental providers, which could happen with co-location, but not necessarily. It could also speak to cross-agency integration or integration between CCOs and the providers of oral health services. So there are a lot of examples of oral health integration that we've tried and probably others. It may refer to the provision of some oral health services such as fluoride varnish by physical care providers. It could refer to payment models that combine payments for physical and oral health services, as well as initiatives that improve communication between medical and dental providers, and that could even be electronic health records. Now the next slide, please. So this diagram you'll also see in the memo or the brief that Carrie mentioned is coming out on the 15th. It's pretty small print, I realize, but it's to show the flow of dollars from the Oregon Health Authority down to the individual dental providers. So the OHA pays each CCO a capitated global budget, and then the CCO makes per member per month payments to each of the providers of oral health services that it contracts with, and then from there the provider of oral health services, the entity, distributes that money to the individual providers in a variety of ways. It could be fee-for-service, it could be salary, it could be PMPM payments, and some alternative payment models, or a combination of those. And you'll hear about some of those variations from our next two speakers. And then also in very fine print at the bottom of this page, it explains a caveat here. This diagram was to simplify the process, but there's also a small percentage of members that are provided care by OHA contracting directly with the DCOs, the dental care organizations. And that, like I said, that's a small number of our patients. And at this point, I want to explain the difference between different terminology you'll see today on these slides and in the report coming out. The original entities that provided dental care in Oregon were called DCOs, dental care organizations, and they existed before the stand-up of the CCOs and the integration. Just lately, we've been making a transition to changing the terminology from DCOs to providers of oral health services. Now, strictly, the DCOs are those entities that contract directly with OHA and not through a CCO. The providers of oral health services are those groups that are contracted with the CCOs to provide oral health care. And we're changing the terminology because now CCOs have the ability to contract outside of the DCO system if they think that's the best way to deliver dental care in their area. So I know that's confusing. It'll be explained pretty well in the report, so watch for that. And the next slide, please. So Chris mentioned what we have, a system called the CCO Incentive Metrics. And within the global budget, which is paid to the CCOs, a portion is withheld each year to create a quality pool. And in 2016, this amount was 4.25% of the total budget. Our 18 CCO incentive metrics are goals that result in incentive payments to CCOs. And of those 18 metrics, 2 of them are focused specifically on dental care, oral health care. One is to provide dental sealants to children ages 6 to 9 and 10 to 14, so roughly the age of first molar eruption and second molar eruption. And then the second oral health metric is combined to require or to encourage that kids that are in the foster care system have a physical, mental, and dental health assessment within 60 days of their entry into the system. So now the next slide, please. This slide is 2 graphs that show our progression in progress on the sealant measure. The one on the left is kids age 6 to 9, and the one on the right is kids age 10 to 14. And you can see the baseline from 2014. And for kids ages 6 to 9, so roughly first molar age sealants, between 2014 and then after the advent of the metrics and incentives, the rate of sealants has almost doubled between the baseline year 2014 and last year. For the older kids, 10 to 14 or second molar age, between the baseline and the 2016 data, the number of sealants has more than doubled in that area. And you can see the small gray bars in the 2015 and 2016 graphs. That's the baseline or the benchmark goal that the CCOs were trying to achieve. And as a reminder, these 18 CCO metrics are metrics for the CCO, so that it encourages cooperation and integration between the CCO and their subcontracted dental care organizations. So this is a good example of where an idea and legislation and creation of our system has led to policy changes, which has led to incentives, which has led to better treatment for patients. Now the next slide, please. So here I've listed quite a few bullets of next steps. I'll go through them a little bit. The first one mentions just an increased awareness of oral health that I've noticed since I began 2.5 years ago. And this is continuing, and part of this is because we created a plan last year across agencies of the Oregon Health Authority to create a strategic plan for OHA for oral health. That involved the divisions of Public Health, the Medicaid Division, Health Policy and Analytics, and the Office of Equity and Inclusion. So a robust cross-agency team that created and is progressing this strategic plan for oral health. Next, it mentions the metrics, and these aren't static metrics. We continue to have conversations about the best way to refine the metrics and encourage better health in all areas. The next bullet mentions our State Health Improvement Plan, which came from our Public Health Division, but it also encourages integration and cooperation between the different arms of the Oregon Health Authority. And of the 7 goals to improve health in the State Health Improvement Plan, one of the goals is to improve oral health. So that's a good example of the integration continuing there. And like I mentioned before, now the CCOs have the ability to contract outside of the DCO systems to meet the needs of their specific communities, and that's where the term providers of oral health services comes from. This year, we just passed a piece of legislation that requires that each CCO has a DCO member on its board of directors, and the bill does use the term DCO, so I expect in rulemaking the semantics of that will be worked out, and it may remain DCO or it may be some form of providers of oral health services. The next bullet talks about a project I'm working on with the Medicaid Dental Program Manager on opioids and dentistry. We want to increase the awareness of dentists' role in the opioid issue. We want to encourage safe and compassionate prescribing, and then also to encourage dentists to register for and also use the prescription drug monitoring program, because dentists really do play a role in the opioid issue, even when we're treating one episode of pain from wisdom tooth removal. And then the last bullet here talks about community water fluoridation, and we rank 48th among the states in the percentage of our residents who have access to optimally fluoridated water, which is the most safe, cost-effective, and equitable way to decrease dental decay and increase health. We're doing pretty well with our oral health goals in spite of our disadvantage that this gives us from the outset. And our State Health Improvement Plan directs us to continue to work to increase our percentage of community water fluoridation. So now the next slide. And now Chris and I will both go over these bullets and talk about some of the lessons we've learned, and then we'll lead into any questions you have.
Yeah, so this is Chris again. We're going to alternate. So the first lesson that we've learned about Oregon's oral health integration work that we wanted to highlight is how essential it is that there's a vision and kind of leadership for this work at all levels. And so in Oregon, we have champions from our current and former governors, and at the legislative level currently, and when CCOs were created, all the way down to the local level. And you'll be hearing some of those leaders from some of those leaders at the next 2 presentations.
And then the next bullet, I mentioned co-location before as one example of dental integration, and we've had examples of co-location in Oregon. I participated in one of them where we had a dental hygienist working 5 days a week in a rural medical clinic, which was part of the system of one of the CCOs. And this hygienist worked there 5 days a week, and then a dentist went out 1 day a week. And when we initiated this, we went out and explained to the staff and the providers the beauty of what we were doing and the value it would be to them and their patients. And we expected our schedules to be overrun with business. And for a while, we just kind of sat there. And we had signs up at the front desk. The front desk people were ready to explain how they could send their patients on to a dental appointment and so forth. But we realized that it needed to be more than just signage and comments from the staff, but we saw the value of the medical providers themselves mentioning it to their patients, encouraging it to their patients, and letting their patients know that they really saw that as a way to improve their overall health. So once we made that transition, instead of just being co-located, we were a little bit more integrated. And we've gone on with other co-location projects from there that have worked well.
So third, we've found that setting broad goals related to the costs and health outcomes, but not being prescriptive with regard to how these goals are met, has been really effective at promoting local innovation and getting buy-in for those that are doing the work. So really just kind of setting the framework and then allowing the local entities that are actually doing the implementation to kind of figure out how they want to get there has been a way to, I think, support local ownership and, quite frankly, pride in their work and experimentation and innovation for what's going to work in their particular communities. And then finally, just kind of this culture shift in established business models also takes time. I don't know if Bruce wanted to say anything about that, but we've kind of found, I think, that there is a different culture with primary care / physical health providers, oral health providers, mental health providers, and it just takes time to kind of shift that culture to more of the partnerships and working toward health system transformation together.
Right, and especially with integrating dental care, and like I said, the DCOs were well-established business entities before we started this path of integration and the CCO system, and that kind of mirrored the profession of dentistry across the country, which has become a little more isolated than other aspects of medicine, even though we're treating a part of the body just like other medical specialists do. So those couple things, the established DCOs and then just the kind of the tradition of dentistry in the U.S. has given us some different challenges. The DCOs were well established in their business models. They were doing fairly well, and there was some trepidation, I think, about rolling their model into a contract with the CCOs, and these things just all worked out a little bit slower than the other aspects of integration, and we're moving along fine. We're not without our daily hiccups and challenges, but I think we're doing pretty well.
So I think that's it for our portion of the slides. I think we're going to pause for questions now.
Great. Thanks so much, Chris and Bruce, for that great overview and context. We've had several questions come in about metrics and measurement, and I'm going to hold some of those until after we hear from our additional speakers and maybe ask those a little later. But one clarifying question that came in was, can you talk about the size of your dental network and how private dentists do or don't fit in?
Some of the dental care organizations and providers of oral health services have freestanding clinics. Some contract with local dentists, and most are a combination of the two. We also, one of our challenges is having enough fee-for-service dentists to cover the small group of patients that aren't enrolled in managed care. So that's an ongoing challenge. Does that answer it?
I think so, and if there's still questions about that, folks listening in, please feel free to chat those in. One other question that has come in, again, it sort of relates to measurement, but is just a question around seniors and whether there's thought or work underway to look at incentives or efforts specifically focused on seniors.
Sure, and we realize that's been a little shortcoming in our system and dental care in general, unfortunately, since dental care is not widely covered through Medicare. And a lot of our measures and focus has been on children, and we really are working now to understand the landscape for care for seniors better. And also, like I mentioned, we have ongoing discussions about how to better refine the metrics. So we're wanting to roll in some metrics that do combine, say, chronic disease with dental exams, or diabetic testing in dental offices, as an example. So that's something we're moving towards, and we realize we don't have as much for seniors as we do for other parts of the lifespan.
Great. And one question related to the cross-agency strategic plan that you mentioned. Was there a particular champion behind that, or champions that you suggest, stakeholders that you suggest as far as helping to move that kind of process along in a state?
Yeah, well, we had a state innovation model grant, which is from the Center for Medicare and Medicaid Innovation from CMS, which was a $45 million, almost 4-year grant to support a lot of our innovation work. And that grant helped support some external consultants that helped with, and Bruce can speak more to this than I can, but helped with kind of identify, do an environmental scan around oral health integration, identify some strategies to improve integration, and basically those documents were kind of the central kind of driving force behind this cross-agency work group, kind of giving some recommendations for how to move forward. And so, in my kind of perspective on it, it was, definitely having a point person in Dr. Austin, who is the dental director, who could kind of serve as the connection between all of these different parts of the agency, but then to have the buy-in from the public health director, from the director of health policy and analytics, which is kind of where Bruce and I sit, from these different health systems division, which is really where the kind of operational components of the Medicaid program sit. To have the buy-ins from those directors as well, that this cross-agency coordination was important. I think all of those were different factors that helped with the kind of success of this effort.
That's right, and a big part of that was that we had a very efficient external contractor that worked with us to do the environmental scan of people within the Oregon Health Authority and around the state, not part of the OHA, but part of dentistry in Oregon. And then we brought that into OHA, and we really had good cross-agency cooperation and interest.
Great, thank you both. Well, there are additional questions that we'll delve into when we get to the formal Q&A portion of the webinar, but thank you again, Chris and Bruce, and thank you those in the audience for chatting and your questions. Now, why don't we turn to our spotlights on local oral health innovations in Oregon. So NASHP spoke with about 30 stakeholders representing many perspectives and learned about innovative improvement and integration strategies across the state. So for example, the CCO Health Share has a strategic focus on performance measurement, including data dashboards with physical and oral health metrics to foster continuous quality improvement and equity among its partners. And provider of oral health services Advantage Dental has adopted metrics related to ED and hospital visits and uses an electronic information sharing network and robust case management to support person-centered coordinated care. Today, we will hear about the work of All Care CCO and provider of oral health services Capital Dental Care. NASHP has given our next two speakers the difficult task of providing a 5-minute snapshot of their work, including who their organizations serve and providing examples of innovation and lessons. And we'll begin with Ms. Laura McKean, who is the Oral Health Integration Manager at All Care CCO. Laura.
Good morning, and thank you for allowing me to be with you all this morning. And I just wanted to give a quick overview of my coordinated care organization. If you can go ahead and hit the next slide. So All Care is one of 16 coordinated care organizations in the state of Oregon, and we serve approximately 50,000 Medicaid members across 4 counties. And you can see there I have the counties broken down and the dental partners that we work with to serve our members. In Josephine County, we have the following partners up there: Jackson County, and you can see also in Jackson County we have La Clinica Dental Center listed, and we do have a direct contract with them, which is one of our FQHC partners, which is a federally qualified health center. Next slide, please. So I was asked to touch a little bit about our alternative payment methodology that we have for our dental partners. And the APM is actually, it's a no-risk program, and it's designed to incentivize the providers to improve upon the quality of health care for our members. And it does not replace the current reimbursement process that they receive, but it really incentivizes them to do these metrics that you see up there and work toward quality health care over quantity. And so this is just an example of the metrics that we have for our dental partners. And at the end of the year, we compile all of the data and we give them a scorecard specific to their dental organization. And one of the things I wanted to touch on was we have citizenship up there. And citizenship we felt was very important to this APM. And that can be things such like participating in health fairs that we have in our area. It could be donating supplies that we might need help with. All Care partners with a lot of FQHCs in our area to put on different events throughout the year, and oftentimes I will call on my dental partners to help us with that. And that's part of the citizenship, and I've always gotten great response from our partners, which is awesome. Next slide, please. So a little bit about oral health integration and my role. You can see up there I bulleted a few things. I really work hard with our dental partners to look at access in our area and make sure our members have adequate services. I receive a weekly report that tells me how we are doing with access. I also work with our coordinated care staff here to see if members have dental issues, how I can help resolve those issues. I am also a first tooth trainer, and I have worked really hard in our area. I've trained over 200 medical providers to do oral health screenings, specifically in the pediatric office, hoping to expand that. But we want them to get the fluoride varnish on the kids' teeth because we found that the kids don't see their dental provider as often as they see their pediatrician. We've also worked with even providers that we don't contract with because they've reached out to us because they think this is just such an important thing. We do a lot of work at All Care at the state level. We are very involved with the metrics for the 2018. I work very closely with my dental partners on these measures. I get a list of the kids in foster care, and I am able to reach out to them if the kids don't get seen to make sure they can get these assessments done. We have done quite a bit of work for our Medicaid Advisory Committee. We convened last summer, probably for like 3 months, I believe, and we worked really hard trying to define access and see where that fits in and what we need to do to improve that for our members. We have some CCO dental work groups that work really hard. These are CCO dental representatives that get together monthly to discuss oral health issues. And we also have several robust local oral health coalitions as well as our state coalition that have worked really hard to improve oral health. Down in my region in Southern Oregon, we have a coalition for Jackson and Josephine County that did a complete messaging campaign last year, and we were able to get a grant. We did a commercial that aired on TV to raise awareness that people had Oregon Health Plan dental benefits, because we have found that people, even though they have these dental benefits, they really weren't aware of them. So we also created a brochure that we are passing out now to all the different places in our towns so people can know that they do have oral health benefits with their medical and their behavioral health. A couple of the lessons learned since we integrated, All Care integrated in 2014 with our dental partners, is it's really beneficial for the CCO to have an oral health person on staff. I know I've been in dental my whole life, and so when I came on with All Care, it was really helpful to them to have someone on staff that knew about oral health and about dental and about Oregon Health Plan dental benefits. And then I also think relationship, communication, and collaboration is key with our dental partners. I work really closely with all of my oral health providers, and I like Dr. Austin how you said that, provider of oral health services. I work very close with those partners, excuse me, and I think having open communication and being able to collaborate with them is going to be key in success for oral health. We're working right now toward integrating oral health into the medical offices, and I like the co-location. That's a great aspect of integrating oral health, and we just want to take it one step further and actually go in and teach these medical providers to look in the mouth when they're looking in the ears or when they're looking at a bump or a broken arm or a runny nose. It only takes a few minutes extra to actually look in that mouth and notice if somebody has an abscess or if someone has some gum trouble. So we actually are working with the state coalition to go into a few offices in our counties and actually provide some education around that. And it's very exciting, all the work that Oregon is doing and our CCOs with our dental partners, and I am just very, very excited and feel blessed to be a part of the work that we're doing.
Great, thanks so much, Laura. One quick question for you was whether All Care saw an increase in dental utilization after the TV spots that you mentioned aired, and how you might have gone about measuring that impact.
You know, I can find that out for you. I'm not 100% sure. That actually was taken on by our Southern Oregon Oral Health Coalition. So the coalition owns the data. We just, the 3 CCOs here in Jackson, Josephine County collaborated on putting that together. So I am happy to find that out for you and see if I can get that forwarded.
Excellent. That would be great. Thank you. So next, last but not least, I should say, we turn to Ms. Linda Mann, who's Director of Community Outreach at Capital Dental Care, a provider of oral health services in Oregon, who will share a snapshot of Capital's work. Linda.
Good morning. Thank you. So I have a tough job of compacting a lot of information into 5 minutes. So if you do have further questions for me after the webinar, feel free to reach out. Go ahead to the next slide. So Capital Dental Care is a provider of oral health services and also a dental care organization. We serve approximately 300,000 Medicaid members across the state, and we contract with 13 out of the 16 coordinated care organizations. We are what's called a blended model, so we have our own staff clinics as well as contracts with private panel providers. Next slide. So with services being provided within 13 different CCOs, the level of integration varies dramatically. We have integration projects that are relatively small and simple, such as providing oral hygiene kits to pregnant moms with the intent to initiate a conversation around encouraging them to seek dental care, all the way to the other side of the spectrum, which is having a full-time co-located expanded practice dental hygienist housed within a primary care medical facility, and pretty much everything in between. We also partner with the Oregon Oral Health Coalition in a successful First Tooth program that encourages medical providers to assess and place fluoride varnish. And the First Tooth program started well before the transformation efforts, but it continues to grow strong. So our goal with integration is to reach patients in locations that they already access or where they live, work, and play. Some examples of this include our teledentistry project, which occurs in various settings such as elementary schools, a county WIC office, a local pediatric medical clinic, and one of our more exciting new projects is to provide services within a DHS-run housing development. The families residing in this setting receive wraparound services including addiction and mental health services, immunization clinics, and classes related to parenting. And now we can include dental preventive services. These types of programs break down barriers such as transportation, time off work, and provide access to very high-risk populations. Next slide. So even before the 2 quality incentive metrics focused on oral health were established, Capital had a robust school-based dental sealant program. But with the addition of the metrics, we've expanded that program to now covering over 100 schools. We focus on kindergarten through second graders as well as the middle school children in 8 of the counties of the state where we are the market share plan. We also contract with other local school sealant providers to help support their program. With the onset of the foster care metric, we do now have a full-time case manager who ensures that every foster child on our plan has a dental visit within 60 days of placement. This slide, I have a correction. This slide should say within 60 days. Next slide. So I thought it was interesting. Some of the lessons learned are similar to the other speakers that have already presented. Integration means different things to different people. We have defined it based on the CCO's needs. It's a fluid process that continues to grow and become more defined as the CCOs mature. There is no cookbook for integration, much to our dismay. The other speakers have pointed out it's all about relationships. And one of the successes, I think, of integrating with the CCOs is the opportunity for new relationships to be made. There are usually a broad range of stakeholders present at meetings, so networking and brainstorming new ideas happens frequently, almost too frequently to keep up with it all. And then finally, just because we think oral health is important doesn't mean everyone else does. Oral health does not seem to rise to the same level as other health needs. For example, behavioral health seems to have been more rapidly and readily accepted in the integration efforts, maybe because medical providers realize the obvious benefits in addressing mental health needs in order to achieve better physical health. An example of this is the case of depression or ADHD. Many times the medical providers are relieved to hand off the patient to a behavioral health provider to assisted treatment. Whereas oral health issues, while they do affect physical health, it's not as well known or as obvious. So it does pose a little bit more of a challenge, raising the importance of oral health. And I think that is it.
Excellent. Thanks so much for your insights, Linda. We do have a couple of questions that have come in while you were talking. So one is, can you talk a little bit more about expanded practice dental hygienists, the services that can be provided, and reimbursement?
So the expanded practice dental hygienist can provide prevention services in community settings without the supervision excuse me, of a dentist. We do have what's called a collaborative agreement clause, where if the expanded practice dental hygienist has a collaborative agreement with a dentist, there are 4 other services she can provide, and that includes local anesthesia, placement of temporary restorations, prescribing of antibiotics, and one other that is slipping my mind. And the second part of that question
was about reimbursement.
So the expanded practice dental hygienists that either are employed with Capital or contract with Capital are paid on a daily rate for the population health services that they provide.
And this is Bruce. I'd like to add one thing to that, Linda. Linda alerted me to a chart from a website that was really impactful for me to see. I've shared it with my dental hygiene students, in fact. But it's on the site oralhealthworkforce.org, and the chart's titled Variation in Dental Hygiene Scope of Practice by State. So you can look on this chart and very easily see what scopes are allowed for hygienists within each of the 50 states, and it's a fascinating comparison chart. Thanks, Linda.
Great.
We also have a pilot project here in Oregon that we are utilizing within our teledentistry model of care that allows the expanded practice dental hygienist to place interim therapeutic restorations in the community settings. This is a pilot project under the expansion of workforce model. So we're very proud to allow an additional practice within our scope.
Great, thanks, Linda. So with that, I think we can move into our general Q&A. So if you have questions that you haven't chatted in or comments that you want to share, please go ahead and chat those in. I wanted to start with some questions that I think each of our speakers might be able to weigh in on. And the first is someone looking for information about how oral health and primary care providers share information and what barriers there might be, and if, I guess if you have them, strategies for overcoming those barriers. So I'll open up to all of our speakers and see if someone wants to jump in first.
Laura, could you answer that? I think you have some examples.
Yes, as far as communication, here in Oregon we have, there's a couple of different programs that are being utilized. One is called EDDI and one is called Pre-Manage. Those are system softwares that people can log into and get information on those. It's a little bit difficult with dental software and medical software because oftentimes they don't talk to each other. I know that there's a new, I think it's called Wisdom Tooth. That's a software that talks to one of the physical health softwares that's used here. But it does present a problem sometimes, which is why I think communication between the partners is so important. You know, that because they don't talk to each other, sometimes I just have to pick up the phone if we have member issues and just talk things out by phone and work it out that way.
Great, thanks, Laura. Another question that's come in, I'm debating how to group these together. There are a group of questions about foster care children, and why don't we start with the metric? So maybe this is a question for you, Dr. Austin. If you can say a little bit about the assessment metric for children in DHS custody, what kind of tool that involves, and just a little bit more about that metric.
Sure, and the metric that encourages providers to do screenings, oral health, physical health, and behavioral health assessment for foster children is for just that. It's to encourage the screenings, the assessments, and those aren't specific to foster children. It would be the same dental screening that we would do for another young child, but it's just to encourage that when a child's new to the foster care system, they have those screenings within the first 60 days of them becoming a new foster child.
And this is Chris, and I pulled up, we have a great reports online. If folks want to go to health.oregon.gov and go under health, I think it's health system performance. And there's the most recent metrics report that we put out. It shows performance on each of the metrics. And the performance in this foster care metric is pretty phenomenal. In 2014, the percent of kids in DHS custody who received these health assessments was at 27.9%. In 2016, it was at 74.4%. Now, the benchmark is 90%, so they still have a little ways to go, but it's pretty remarkable how kind of setting up this metric has really caused this behavior change at the delivery system level. And just as a side note, what we hear is that this metric in particular has really, pardon the pun, but fostered collaboration between the kind of health care system and their community-based partners that deal with that kind of support the foster youth as well. So it's been a really important metric for supporting innovation.
And similarly, Chris mentioned some of the increases in other metrics. I showed the graph showing the increase in sealants over the last 2 or 3 years. And the sealant programs have become more robust, partly because of the metric and partly encouraged by legislation. So it really is the different partners working together to see how we can make things work out or encourage providers to provide better care overall. And the numerical increases has really been astounding.
And just to finalize, since there are a lot of questions on metrics, I want to be clear where you can find the metrics report I alluded to, health.oregon.gov, and then on that page, click on Health System Reform, and right under that is Health Analytics Data, and you'll see a bunch of reports, and the one I'm looking at is CCO Metrics 2016.
Great, thanks, Chris. Question about a specific service. So, and again, this might be for all of you and maybe more so for Linda and Laura. And this is about whether any of your providers or organizations are using silver-diamine fluoride and sort of if you can speak to how well accepted it might be in the state.
This is Bruce. I'll jump in ahead of that invitation to Laura and Linda. And I think I saw that Dr. Bragg from Oklahoma is on the webinar too. He gave a presentation at the NASHP conference in November about FDF, and at that time Oregon was the first state to allow Medicaid reimbursement for the use of silver-diamine fluoride. So we have seen quite a bit of use of it. At first, there were concerns about it, and we were careful with communication. We were careful not to reimburse it at such a high rate that it would discourage other conventional treatments. And it's gone pretty well. We don't have good numbers yet because we just started covering it in the last year or two, but we haven't had specific problems with it, and it looks like another good tool in the tool bag for attacking dental caries.
Great. Linda or Laura, did you want to add anything to that?
This is Laura. I think I'll let Linda speak to that since she's with the dental organization.
I would agree with Dr. Austin. I think it's a great addition to the tools that we have in our tool bag.
Excellent. I guess one final, this is a broad question, but I think it's a good question that I think applies to each of you, is a question about how you define success. And we're down to our last couple of minutes, so I guess I would just ask each of you if there's something you could share about how you define success when it comes to this topic. That would be helpful, and I'll leave it to you as to who wants to jump in first.
So this is Chris. I'll jump in and kind of with a broader statement and then leave it to the others to talk more specifically on oral health. I would say how we define success in terms of our health system transformation overall is really with the triple aim in mind. So better health at lower cost. But then specifically when it comes to Oregon's model, I would say the metrics piece, kind of the continual evolution of the metrics, and I don't think we really touched upon that, but these metrics are not static. They're moving over their time. We try not to change them too much, but we're going to kind of continue add metrics to kind of push innovation, drop metrics where CCOs are really showing that they're doing just fine, and then kind of moving the target over time as well. So I would say success is not a static point in time, and we're not going to ever be there definitively. We're just going to kind of keep on evolving and moving and innovating, and because this work is just needs to continue in that direction. So Bruce, I don't know if you have anything to say specifically around oral health or.
Well, and to continue that, like I mentioned, we've seen such an increased awareness of the importance of oral health, and I chuckled when Linda said just because we think oral health is important doesn't mean everybody does, but now everybody's at least understanding why it should be important to them and their patients. And we've mentioned decreases in cost, we've seen decreases in emergency department visits, and just markers of healthier patients overall. And as a dentist treating patients for over 30 years, I still like to take it back down to the individual patient level, and we're seeing happier, healthier patients.
This is Laura, and I think I would echo what Chris and Bruce said and just add that continuing to make sure that our members have good oral health benefits, have access to those benefits, and even the awareness that they have benefits, keeping that raised, and just make sure that these medical providers, that they are taking an interest in the mouth, because the mouth is such an important part of the overall health of a body. And so that's what I would say.
And I would echo that and take it down even one more notch to my favorite success story of a child of a blind mother who came to school with pain and abscess, and because we were there providing teledentistry services, we were able to help that child and case manage them into one of our clinics, where if we wouldn't have been there, they would have ended up in the emergency room.
Great. Thank you all so much. So thank you to Krista Mars, Dr. Bruce Austin, Laura McKean, Linda Mann. Thank you again to the DentaQuest Foundation. I also want to acknowledge my colleagues Amy Clary, Najee Mention, and Jill Rosenthal of NASHP. NASHP compiled a list of resources which you saw. Our report about Oregon will be coming out on August 15th. And again, we ask that you complete the short survey that will come up on your screen. We use it to inform future events, and today's materials will be posted on nashp.org within a week. So thank you all and have a great day.
Again, that does conclude today's program. Thank you all for your participation.